Okay, this is Professor Garvey on a snowy Sunday afternoon. The fact that I've decided to record this lecture for tomorrow probably means that we won't get any snow tonight. That always seems to be how it goes. But just in case, here it is, and I know you all love the opportunity to potentially learn about diseases in your fuzzy slippers. So I hope you all do that with a little cup of hot chocolate. Diabetes type 2. Okay, so our questions to consider. So the first question is short-acting insulin secretagogues are faster acting than sulfonylureas. So they may be especially effective to control what type of problem? So just think for a minute about where in diabetes do we think a very fast-acting medication might be helpful? Question 2. In many patients with type 2 diabetes, glucose levels are adequately controlled with lifestyle changes or oral drugs, and insulin is added when glucose control remains inadequately controlled by more than 2 oral drugs. Adding insulin is most effective in combination with which oral drug? Question 3. Diagnosis of diabetes mellitus is suggested by typical symptoms and signs and is usually best confirmed by which fasting test? Question 4. Patients over 45 with an impaired fasting plasma glucose level, which would be 100 to 125, and other risk factors should be screened for diabetes at which interval? Okay, so definition of diabetes. Diabetes is a group of metabolic disorders resulting in hyperglycemia. This is a complex interaction between genetic and environmental factors. So some contributing factors include, for type 2 diabetes, deficient secretion of insulin by pancreatic beta cells, decreased glucose utilization, increased glucose production, and resistance to insulin effect peripherally. So all of these factors together are working to raise the glucose level in the bloodstream. I did post some links on Blackboard to some Khan Academy videos on the pathophysiology of both type 1 and type 2 diabetes mellitus. I highly recommend you watch those. I'm going to cover the pathophysiology a little bit here, but that I thought did a good job of giving a broader background. The epidemiology of diabetes, it's very prevalent. You can see that there are certain areas of the countries that have more diabetes than us, but that we, especially for a country of our size, are right up there. And then this slide also is showing how the percentage of people with diabetes are increasing over the percentage of the total population. So you can see how now the number of patients by percentage of diabetes just since 2000 even have really gone up. Okay, and this is an age-adjusted prevalence of diabetics in the United States. Kind of reminded me a little bit of the kidney stone belt map. You can see southern states have more prevalent diabetes than some of the northern states, but it's pretty much over 6% of the state for all of these. So in 2015, which was the most recent data I could find, 30.3 million Americans, or 9.4% of the population, had diabetes. 1.25 million had type 1 out of that. And then undiagnosed, of those, 23% 8.1 million were diagnosed and an estimated 7.2 million were undiagnosed. It's quite prevalent in the over 65 group, 25% of that population. But 1.5 million Americans are diagnosed with diabetes every year. And 84.1 million 18 and older had pre-diabetes, which, depending on where you look at it, may also be reclassified as high risk for diabetes. And it's the 7th leading cause of death in the United States. This is a slide looking at the classification of diabetes. So, based on results of testing, so you have normal glucose being a fasting under 100, or a 2-hour glucose test below 140. Sorry. And then a hemoglobin A1C of less than 5.6. Pre-diabetic, which in some classifications is now being reclassified as high risk for diabetes. So fasting plasma glucose below 125 and 2-hour below 200. A1C up to 6.4. And then we'll get into this more when we talk about criteria for diagnosing someone with diabetes, but those are the numbers there. Greater than 126 on a fasting, greater than 200 on a 2-hour, and greater than 6.5 for an A1C. Okay, so the pathophysiology. So glucose homeostasis is always the balance between the stored glucose in the liver, which is meant to release to bring our glucose up when we have low blood sugar levels, and our peripheral glucose uptake, which is how we store excess glucose when our blood sugar is high. So this is meant to maintain our glucose in that normal range for people who do not have any impairments in their systems. When a person is fasting, the low insulin levels trigger the liver to release stored glucose and reduce glucose uptake into the muscle and fat. The glucagon is released by the alpha cells of the pancreas when low blood sugar or insulin is sensed. So this is the process by which we normally would maintain our blood sugar in a normal range. Then after we eat, the glucose rise triggers the pancreatic cells to release insulin to reverse the process and begin the storage process. It also stops glucose production by the liver. The brain, however, is independent of this process and can uptake glucose without the presence of insulin, and that's just to protect our brain cells. So two things influence diabetes development: genetic predisposition and their lifestyle, their activity, and their diet. So if you are obese and sedentary, you are going to contribute to insulin resistance. If you have genetic predisposition, you do not have to be obese to develop type 2 diabetes. A patient either has genetically programmed normal beta cells or genetically programmed abnormal beta cells. If it's normal, then he will compensate and remain normal glycemic. They might develop metabolic syndrome, but not really hyperglycemia because they're able to compensate. If they're genetically abnormal cells, then they can go on to develop type 2 diabetes. About 20 to 25% of patients at risk with normal cell function will deteriorate into abnormal cell function. So that's this group. So there's the three problems: the insulin resistance, the impaired insulin secretion, and the excessive hepatic glucose production and release. Insulin resistance in the liver leads to the failure of high insulin levels to stop release of stored glucose, resulting in fasting high blood sugar. And this happens early in the course of diabetes. So the risk factors for developing type 2 diabetes: obesity, age over 45, a family history of type 2 diabetes, someone who's physically inactive, and then if a woman has a history of gestational diabetes or giving birth to a baby 9 pounds or more, that's a risk factor. And then certain ethnic groups: African American, Hispanic, American Indian, and Alaskan Natives. Okay, so who should you consider screening for diabetes, even if they are an asymptomatic? So testing should be considered in overweight or obese individuals who are in a high-risk group or have risk factors. So this could be someone with a first-degree relative with diabetes, so again, that family history, the high-risk ethnic groups, someone with a history of cardiovascular disease, hypertensive, high cholesterol, women with polycystic ovarian syndrome, people who are physically inactive, or those other conditions that can be associated with insulin resistance. So severe obesity, and then if you saw someone with acanthosis nigricans, which we're going to see pictures of that later. So, and then anyone who is at in that high-risk pre-diabetic group, so if they had the A1C greater than 5.7 or an impaired glucose tolerance test, then they should be tested yearly. Women who had gestational diabetes should be tested at least every 3 years, lifelong. For other patients, they should be tested at 45 years if they are not in the high-risk group. And then if they're normal, they should be retested at 3-year intervals. All of these other high-risk groups should be tested at annual intervals. This is just an example, at least, of a survey that patients could do to help them estimate their risk. Okay, so then risk-based for kids and adolescents, those who are overweight, greater than 80th percentile for BMI or weight for height, plus an additional risk factor. So maternal history of diabetes or gestational diabetes when they were pregnant with that child, family history of type 2 in a first or second degree relative, someone in a high-risk ethnic group, or if they have signs of insulin resistance, then they should be tested. What kinds of history or symptoms are we looking for patients with diabetes? And most often they are in type 2 asymptomatic at the time that they are developing this. But if they are going to have symptoms, then polyuria, polydipsia, and polyphagia, so frequent urination, increased thirst, and increased hunger are kind of the triad that is referred to most often. Weight loss is also in there. Is something that, especially on board questions, they like to throw in. Chronic skin infections, so patients who have either things that don't heal on their skin or get fungal infections easily. They're tired, they may have blurry vision, signs of peripheral neuropathy. In women, if they have recurrent candidal vaginitis, that would be a red flag. And again, history of gestational diabetes or large babies. And in men, balanitis. So what findings are we going to see on physical exam for type 2 diabetes? So a fat distribution where they have a lot of central obesity. So fat on the abdomen, chest, neck, and face. Now this looks different than Cushing's disease. It's not a moon face. It's kind of just an overall obese. Acanthosis nigricans. We'll show a picture of that in a minute. High blood pressure, diabetic eye changes with hemorrhages and exudates, and signs on neuroexam of peripheral neuropathy. So decreased sensation to light touch, decreased sensation to temperature, problems with proprioception, and loss of deep tendon reflexes. And then findings, especially on foot exam, of ulcers on their feet, dry feet, claw toes, or Charcot joint. So this is an example of acanthosis nigricans. So this very hyperpigmented plaque can be on the neck, side of neck, back of neck, axilla, arms. But it's like this thick hyperpigmented band. And this is an example of Charcot arthropathy. This happens because of repetitive injuries to the tendons and tissue in the feet because the patients can't have normal sensation there, and they don't realize that they're having these kind of recurrent micro injuries. So how do we diagnose someone for diabetes? So we have the what levels are considered normal in the first category here. So fasting blood sugar below 100, 2-hour plasma glucose greater than less than 140, A1C under 5.5. High risk for diabetes here, and again some groups call this pre-diabetes, some call it just high risk, but the numbers are essentially the same. I believe this slide I took from the American College of Endocrinologists, and there are some slight differences between that and like the American Diabetes Association, mostly in this high risk category. But then to diagnose diabetes, so fasting greater than 126, 2-hour plasma glucose testing greater than 200, or a random greater than 200 with symptoms, or an A1C greater than 6.5. Generally, A1C should just be used for screening, not for actual diagnosis, because it can have some fluctuations. So if you got an A1C of 6.5, then you'd probably want them to come back for a fasting plasma glucose test. That is the preferred test to diagnose. You might also check urine glucose. This may point you towards diabetes. It's not diagnostic because there can be some other conditions that might cause that. Urine and blood ketones. You can also do a serum fructosamine test, which reflects what their glycemic level has been over the past couple of weeks. treatment. So first we're going to want to try to have them make lifestyle changes. We want them to be aware of good nutrition. If they are obese, we want them to try to work towards getting down to an optimal weight, although even slight weight reductions can be helpful. We want them to try to increase their physical activity, so they're doing at least 150 minutes a week of moderate exertion. They need to start slow and build gradually if they've been pretty inactive, and they may need some medical clearance to start a program like that. We want to make sure that they're getting about 7 hours of sleep a night, and that if there is any history that makes them at risk for sleep apnea, we want to get that diagnosed and treated. We want to suggest that they get involved with some behavioral support, whether that's joining a diabetes support organization or an online group. We want them to drink alcohol only in moderation and to really try to get them to quit smoking. So looking at it a little more specifically, so weight loss. Initial treatment goals should be to reduce their weight by 5 to 10%, increase their physical activity, so diet, eating regular meals and snacks, trying to have a high fiber, reduce their calorie and watch the glycemic index of their foods, learn a little bit about reading nutrition facts, and they want to have healthy carbohydrates, fresh fruits, lots of vegetables, whole grains. Watch their fats, making sure they're getting more healthy fats and limit saturated fats in their diets. Have their proteins be chosen more from groups with low saturated fats. And generally they don't need a lot of micronutrient supplementation as long as they are working towards a healthy diet. So if they're in that pre-diabetic or high-risk group, this algorithm just points out that we want them to continue throughout this whole algorithm in improving their overall healthy lifestyle, that we also want to start targeting those who have risk factors for atherosclerotic cardiovascular disease, seeing if they have dyslipidemia or hypertension, that we want to assess those and get those treated. That if they are moving down this pathway towards overt diabetes, that we want to start trying to get their glycemic control there. So if they're hyperglycemic, even if they are not at the level to treat diabetes, and they have some other risk factors, we might want to either intensify their weight loss therapies, do some low-risk medications like metformin or acarbose, or consider some other medications. So medications used for treating diabetes, oral medications. I'm not going to go through all of these in detail. You're going to get these in pharmacology. And there are a lot of them. So the things to note are what advantages and disadvantages each medication has. So just keep in mind that the way you decide which medications you might want to target have to do with this particular profile for each medication. So how effective are they? How much reduction in A1C can you expect to get? What advantages or benefits might a particular medication have over others? So do they have a benefit as far as their weight, as far as their risk of hypoglycemia? Do they have specific contraindications, like in renal impairment? Or do they have specific disadvantages that would make that a poor choice? So metformin is pretty effective. It's usually one of the first line ones used. The glucoside inhibitors are particularly good at reducing postprandial glycemia. The peptase inhibitors are generally well tolerated and are not an issue with hypoglycemia. The sulfonylureas, the secretagogues, these all have risk of hypoglycemia. They're pretty short acting, so they are again good for postprandial glucose highs, and they're cheap. Then insulin secretagogues that are non-sulfonylureas are very short action and are good at helping control postprandial highs but can have some hypoglycemia associated with them. The okay, I can't say that today. Thiazolidinones, rosy and pioglitazones are somewhat effective. They can get a reduction up to 1.4, but they can be particularly problematic in patients who have edema. They can cause weight gain. You don't want to use them in CHF patients. And then we have some parenteral agents here. These are used a little bit less often. And you can see their safety profiles until we get down to insulin. So how do we decide which ones we pick? Well, we want to make sure we're picking ones that are efficacious. We want to keep in mind their hypoglycemic risk and their effects on weight. If you have someone that's trying to lose weight, you want to either pick a weight neutral or one that has an effect of helping with weight loss. You want to keep in mind their major side effects. And all of them except for metformin and sulfonylureas are pretty expensive, so that can be a factor as well. So this is again from the American College of Endocrinologists. I kind of liked this way to help you think about glycemic control. So if you start on this side over here, if you're just starting someone on one medication, these little bars here kind of indicate the suggested hierarchy of usage. So you can see typically someone on monotherapy, metformin would be the drug of choice. And then as you go down the line, they're a little bit less often used, usually because they have more side effects or other issues. So you start someone on monotherapy. If they are not at goal after 3 months, then you want to step them up to dual therapy. So then if you started them on metformin or some other first line agent, this is usually the selected hierarchy for choosing second line agents. 3 more months go by, now you're maybe moving towards triple therapy. And again, the hierarchy of which ones you might choose for the next one to add. Then another 3 months, you are going to usually add or intensify insulin. And which might mean if you're starting someone on insulin that you're dropping some other things. Now, if someone at diagnosis is already at a really high A1C, you may skip a couple of these steps and start them on dual or triple therapy, or even on insulin based on how severe their symptoms are at time of diagnosis. Well, this is just another look at profiles of anti-diabetic medications, what side effects, symptoms, effects on weight are, and hypoglycemia. So you can see these two groups are particularly concerning for their risk of hypoglycemia, along with insulin. And you can see that which ones are problematic from a renal GU standpoint. And then here's an algorithm for if you are starting insulin. So you usually start with basal or long-acting insulin, depending on what their A1C is. TDD is total daily dose, how many units per kilogram you're going to start with. And then you titrate them up every few days until you're reaching their glycemic goal. So a glycemic goal for most patients with type 2 is to get them below 7% A1C and fasting and premeal blood glucose below 110. And then this is moving over for intensifying when you add a bolus of insulin. So you would add insulin before their largest meal and then progress from there until you reach the goal. And we'll talk about this even more when we talk about type 1 diabetes, about insulin adjustments. So anytime you have a patient, especially on insulin, but even on some of those oral agents, you need to be aware of hypoglycemia. So typically, hypoglycemic symptoms might start when the patient's blood sugar is below 70. Mild symptoms, they may have some palpitations, tremor, hunger, sweaty, anxious. Moderate symptoms, then they may have some behavioral changes, they may be emotional, be confused, have troubles thinking clearly. Below 50, then they're usually severely confused. They may be lapsing into unconsciousness, seizure, coma, or death. So this is typically where they're going to need to be treated with like an injection of glucagon, where typically up in these areas you're having them treat with some oral agents. So if they're conscious and alert, you're going to have them take some glucose-containing foods, juice, crackers, milk, hard candies, insulin gel, or I'm sorry, glucose gel, glucose tabs, and then they're going to recheck their blood sugar after 15 minutes. If it's not into the safety zone, then they're going to consume something else and check again in 15 minutes. Once their blood sugar is getting back into the safety zone, if it's more than a couple hours to their next scheduled meal, then they need to have an early meal or snack. Obviously, if they're down this pathway and they're not able to safely consume a beverage or food on their own and they're very confused, they're going to need a glucagon injection and then they need to be hospitalized. So things that we're going to be doing both at an initial visit where someone's being diagnosed for diabetes and then for ongoing care. So we're going to be talking with them about their glycemic control and how we can get that optimized. We're going to have them check their blood sugars at home. How frequent depends on how severe their symptoms are and what kind of medications they're on. Typically, for someone who's newly diagnosed, who's maybe just on some oral medications, we might be having them check a fasting and maybe a 2-hour postprandial after their biggest meal of the day. More frequently, if we're adjusting medication dosages or if they've started something new or if they're ill. And someone who's on a more intensive regimen, like multiple medications or insulin, might be checking their blood sugar 3-4 times a day. Hemoglobin A1C testing, usually most places we want that tested about 4 times a year, unless someone's really stable or maybe just newly diagnosed in that low threshold, just on one oral agent or maybe just working on lifestyle modification. They need to have some diabetes education at least yearly. Recommend that they have some self-management education and maybe some support group. They need to have some education annually about their nutrition. They need to have an annual eye exam, and every 6 months to annual foot exam, or often if it's they're having problems or if their diabetes control is not good, and they need to be checking their feet daily themselves. They need to have screening for diabetic nephropathy at least annually. They should be having their blood pressure checked at least quarterly and every time they're in. Lipid profile and creatinine annually. They need their immunizations updated. They might need antiplatelet therapy.